Hello, I'm Joni Alberg, and welcome to our closing keynote session, Long-Term Communication Outcomes in Children Using Cochlear Implants. With me today is Eliana Fredes, who is here to translate any of your questions from Spanish to English for us. And now, without any further ado, I am going to introduce our presenter, Dr. Shani Detman, who is an associate professor who has worked as a speech pathologist and clinical researcher in pediatric cochlear implant field since 1987. Shani has authored or co-authored over 53 journal articles, 5 book chapters, and 200 conference papers regarding factors affecting communication outcomes for children with hearing loss. Very much looking forward to your presentation. Dr. Detman, I turn the microphone over to you.
Thank you very much for that introduction. I'd like to start by thanking the organisers for this opportunity to share some of our data. And I acknowledge here Dr. Dawn Chu and Professor Richard Dale, who are long-term research collaborators. I also like to acknowledge the wonderful staff at the Cochlear Implant Clinic, and they're listed here. And all these other names on my opening slide are students that we have supervised in this project. Long-term outcomes. The objectives are to look at the evidence that supports very early access to hearing. In addition to age at implant, what are the other factors? Child factors, device factors, and family environmental factors. And at the end of my presentation, or towards the end, I want to introduce very briefly an implementation science framework to think about intervention. So the context of this study is first, an overview of factors. What is long-term? And I'm going to be presenting some studies that go to school entry, to 9 years of age, and to adolescence. Summarising what's happening in aged implant in other countries. Number 5 is getting to the implementation science framework and conclusions. What have we learned over the last 40 years? So this lovely image here is the Royal Victorian Eye and Ear Hospital in East Melbourne, where all the magic happens. We started on the 2nd floor and it's presently on the 6th floor in this building. I give a lot of credit to Professor Graham Clark, who gathered together multidisciplinary teams very early on. He clarified what was needed, he identified barriers and enablers, and he made particular selected interventions. And I think the key was that we were all so trained to measure outcomes, to test, to apply the appropriate test and measure what we're doing. You can see big teams here that always include, of course, the surgeons, speech pathologists, audiologists, and the medical admin, but also we had access to psychologists, engineers, speech processing engineers, software engineers. It's been a wonderful career the last 40 years. So the pediatric program was since 85. So the first kids in the world were a 15-year-old and a 9-year-old in 85. And then in 1986, it was the first 5-year-old. And I was lucky enough to work with those kids. We always entered the data into a dedicated pediatric database, right since 1990. As soon as we had any information on the families, the environment, where they were going to school, what's happening with the child, the device, and the family. And this was always entered into a database. So I think it's a unique repository of this information. And parents opt out if they don't want their child's data to be used, but most of the data is in this unique pediatric database available for retrospective studies. So here are the 3 factors that Gears and Moog talked about way back in 2003. Factors associated with the child, the device, and the family. And I want to say a couple of things about those. I'm just going to move the screen out of my view. There we are. So when a family or a parent says, oh, my child had the implant, but it didn't work, we don't know why. It's rarely the case. We do know why. We do understand the factors. We've known about the factors since 2003. The field has changed a little bit though, and we need to think about current cohorts. If you're reading journal articles that were back in 2000 or 2007, that's old data on children using old speech processors. And those kids probably had the implant at a much older age, and they probably only had one. Today's children might have the implant under 9 months of age. They often have two, and of course, they're wearing the most current speech processor. So I've been a bit harsh on the data that I've selected, and I've tried to only include empirical papers, not opinion pieces, not reviews, and I've only included current papers. So let's have a look at some factors. Firstly, and very clearly in a range of papers, is the child's learning ability. So it's sometimes called cognitive ability or non-verbal cognitive ability, and whether or not the child has another diagnosis. And we know up to 40% of children who have profound hearing loss also have something else going on. What about the device? So how severe is the hearing loss is relevant to hearing aid users. What about the age that they got their hearing aid? Earlier is better for cochlear implants. Before 12 months has been in our papers. Before 9 months has been in my most recent paper. And also data logging tells us about how many hours a day is this child wearing their device. The absolute minimum is 8 hours a day, in my opinion. And I would say that it should be every waking hour that the child brain is listening and learning to listen. So you can see I've crossed out John Naparko. I've crossed myself out as well in a few places, and I'm just reiterating that point that that's old data, old speech processes. Family environmental is the last bunch or group of factors. So the parents' education, the mother's education, how wonderful is that linguistic or language input to the child in the first year after the implant, whether they're using auditory verbal, auditory oral, or a signing-based communication approach, and general indicators of socioeconomic status, so relative advantage. And that's sometimes measured, certainly in the US, by what insurance type you have, or the family size, or even the amount of hours that the family can spend looking at books. So when we have a look at all of these factors, some people get quite cross when we talk about differences, children in an oral program versus children in a signing program, or children from lesser socioeconomic advantage. People get cross, and I have a theory on that. Here's our three factors still: child factors, device factors, and family factors. With the child factor, it's not changeable. We understand the diagnosis. We may have grief and sadness and anger, but we move on. It's not something we can change. Whereas these, the device choices and the family environmental choices, are something that we can be a part of. And anytime a parent, you remember this for yourself, anytime you make a decision for your child, you're weighing up the information, you're looking at the pros and cons, you're thinking, what's doable for my family? And then there's those consequences of that action. With child development, we can't get that time back again. We can't say, oh, no, change my mind, I want to do the other decision. So we have some emotions that go with these factors. We have regret. That's an emotion about what I've done by my own agency. Did I do this? Should I have done more? I should have always done more maths with one of my boys. I always planned to sit down and do more maths practice with him, but I regret that I didn't. And disappointment is another emotion. It's more about what others have done. Did I not get the right information from them? Was I misinformed? I can't really recall that information. So I think this is why people get cross and angry when we present information about device and family and environmental factors. So let's look at the data where children have used implants and they've been followed to school entry. I want to start just by saying the differences between prospective studies and retrospective studies. In prospective studies, often the researcher has a big bucket of money and has been able to invite participants to be part of the study. They tend to be a bit smaller and they tend to include those parents who say yes. So they have definite advantages in that the children complete a range of tests. And our gold standard for that are the Lockheed studies. So Lockheed is longitudinal outcomes of children with hearing impairment, LOCHI. Children were invited to be in the Lockheed study and they were tested at 3 years, 5 years, 9 years, and so on. Retrospective studies might use an existing database. The researcher doesn't necessarily have a lot of funding, that's me, and might use an existing database, such as our paediatric database, or might visit the hospital and go through all the medical records. So they tend to be larger studies. They tend to include everyone. The best retrospective studies include everyone. And they also include families have a range of socioeconomic backgrounds, and they include the children who have additional diagnoses. So I'll spend a little bit of time on these two studies. This one in 2016 and this one more recently in 2021. So this is our 2016 result. There's a lot in this paper. This is the speech perception results. And what I want you to focus on is the children who received an implant very young, under 12 months of age. Here is group number 1. And what you're looking for is the triangles. Here's our triangles here and here and here. They are group number 1. So those children received an implant under 12 months, and group 2 received it between 13 and 18 months. And you can see the breakdown of group 3, group 4, group 5. Try to keep that grouping in your mind. Along the bottom here, we've got the phonemes. Does the child hear the sound and they get the right sound? Do they get the right word? Do they get the right sentences? And what we've got here in our results is that the children who received an implant before 18 months, so that's group 1 and group 2, had significantly better listening skills, so speech perception skills, than the other 3 groups for age at implant. Now, what about speech production? We see the same thing. Here's our triangle kiddies who had the implant super early, before 12 months. Along the bottom, we've got the vowels. How clearly do they say their vowels? Don't make any jokes about Australian vowels here, or g'day, those, okay. So vowels, consonants, and phonemes. Phonemes is just putting vowels and consonants together. Clusters is the when we have 2 consonants side by side. So if I say blue, but all is a blend, or if I say strong, is a cluster. They're a little bit poorer than vowels and consonants. And then over here, we've got word intelligibility overall. Our triangle kiddies are doing better in their speech production. Those children who received an implant early have significantly better speech production than all the other groups. What about language? We've got the preschool language scales here on this side and the clinical evaluation of language fundamentals on this side. I'll just orient you to the green area. The average here, and you'll see this on many of my slides, the average is 100 and it's plus or minus 15. So this is the normal range for typical children. So a whole bunch of hearing children do these tests as well, and we know what is average. Let's look again for our little triangle kiddies. The group 1 children were significantly better. In fact, look at them, they're in the normal range if they received an implant under 12 months. And that's the similar result we see for the clinical evaluation of language fundamentals. So 64% on this test were in the normal range if they received an implant under 12 months, and 58, about half, are in the normal range. This last test is the Peabody Picture Vocabulary Test. It's just vocabulary, the words that the child knows. Once again, we've got the normal range for typical developing children. And here's our result, where the children with an implant under 12 months were significantly better than all other groups. Also, the children that received an implant between 13 and 18 months was significantly better than all other groups. So on this side, people sometimes, instead of having the grouping, it's exactly the same data, but now you see the individual children. The red children have normal or typical learning ability, and the grey children have an additional need. They need support in the classrooms for their learning. So we've got the red, typical development, and the grey requires support. What we can see is that there's an age effect, better language, the younger the child has the implant, and that result still holds for children who have another diagnosis. 80% of the children who had the implant in younger than 12 months actually fall in the normal range for vocabulary. So that was the first study. Let's update that in 2021 with this study. We focus now not under 12 months, but under 9 months. So there's a few things to say about this slide. Let's orient you. Once again, this is our normal range in green, but our axis is a little bit different. What we did is we put all the language tests together. It didn't matter if they did the Minnesota CDI or the Rossetti infant toddler language scales, or maybe they did the PLS, preschool language scales, or the Peabody picture vocabulary test. Whatever test they did, we pulled the data and made a ranking. From 0 is no language ability, right through to 7 is super child. This is a child who has above average language. So green is the normal range, and we've got our red and our grey again. The first thing to say is that the children who received an implant under 9 months are here in the normal range, but you'll see a missing grey bar. We didn't go ahead at that stage with children who had another disability under 9 months. Of course, they did go ahead between 9 and 12 months, but not this super early age group. And I think that's intuitively consistent. The children who had an additional disability take a bit longer, a bit more testing. They have lots of other appointments that they're going to. So this is the same result once again, but people like to see it as a scatter. We have the red children who have the typical development, and the grey children have that additional learning need. What we can see is that the age at implant effect is still there for both groups. So earlier is better. It's a fairly clear statement. What about following them to 9 years of age? I have a real problem with many of my studies in that the data stops when they get to school entry. But the Lockie study has been able to follow children to 9 years and beyond. This is their most recent publication in 2025. And there's a lot on this slide, but let me tell you that cognition, language, and reading were within the normal range. 2 of the tests, recalling sentences and following directions, were just outside the normal range, but quality of life, measured by the parents and by the children, was within the normal range. So instead of reading that very busy slide, I've popped them here. This is our normal distribution. There's 100 children here. And what we can see is that the Lockie data is saying word classes, sentence tests, vocabulary tests are within this normal range. So this darker blue is the range we'd expect for children who have hearing and typical development. Here's our children using hearing aids and implants here in the normal range. Same, in fact, recalling sentences and following directions falls just outside, but reading was within the normal range and understanding passages was within the normal range. The pink is our quality of life measures as measured by the parents and also as measured by the children's own self-report. So this is an outstanding result for children with significant hearing loss. It's a prospective study, and Teresa Ching and her team, she led the Lockie study. As I said, gold standard, has quite a series of publications that you can find. The most recent ones was talking about quality of life and psychosocial aspects. They found no direct relationship between early and psychosocial, but there was an indirect effect. So language and communication were definitely affected by age at intervention. And then there was that flow-on indirect effect to psychosocial development and quality of life. And I asked Teresa Ching permission to use this slide just to show how complex it is. Here's our child factors that I've introduced to you. Here's our family and environmental factors that I've introduced. Cognition certainly plays a role. And here's some of our outcomes: language, health-related quality of life, and speech perception. So just look at how crazy and complicated those links are. So have a read of the 2025 paper. It's complicated. What about to adolescents? There's far fewer papers that have actually followed children long term. Some of these studies here that you'll see, Pisoni, Gears, and others, are US based. And as you might know, the Food and Drug Administration guidelines did not include children under 12 months until recently, and still doesn't include children under 9 months. This Italian study, Coletti, did have some children who were under 12 months and followed them, but it's a good example of past data. Look at the date, 2011. It's past cohorts, old speech processes, the kids using what we call legacy speech processes and implants. So I want to spend a bit of time on two of my studies. So this is a prospective one of reading, phonological processes and literacy, and then I'll look at this study, which is a retrospective large study. So the first one was enabled by our Hearing CRC, which is the Hearing Cooperative Research Centres. They provided some funding, and we invited all children who had an implant very young, under 2, and who'd been using it for 10 years. So at that point, they were the youngest in the world to have received implants, and they'd used them the longest. So I flew all over Australia and tested some of these children, and here they are. So 9 girls and 16 boys. 8 of them had the implant under 9 months and been using it 10 years, 2 between 9 and 12 months, and 15 between 12 and 24 months. All of them had 1 implant, but then went back for a second implant, except for 1 child who remained with 1 implant. Their early intervention was 10 of them auditory oral, 14 auditory verbal, and 1 child had deaf parents, so she had speech and sign and auditory verbal. They were 14 when we tested them, and I just want to point out their socioeconomic index for areas. That's CEFA, and that's a very broad brush stroke on their relative socioeconomic advantage. So these children were from a relatively high socioeconomic advantage. Their CEFA was 8. And how do I know it's a bit high? Because when I did that analysis for 1,000 children that were in our pediatric database, our median was 6. So it's that issue that we have with prospective studies sometimes, that the parents who say yes and the teenagers that say yes might represent a higher relative advantage area. So keeping that in mind, I did all of these tests. So the test of phonological processing, the Woodcock reading mastery test, and just 1 subtest of the TAL, which is a written language. Let's have a look. The 25 children completed all of these subtests along the bottom. They have to look at sounds, manipulate sounds, remember them, say them back. There's a whole lot of subtests in the CTOP, which is Comprehensive Test of Phonological Processing. And just to orient you to the slide, here we have our average again. So the normative samples, children who have normal development and normal hearing. And here's our 25 children right in the average range, which is absolutely wonderful to see. Some people like to see the individual kids. So this is the same data, but the dots represent the 25 children in all of those subtests. The CTOP also gives you a cluster, so phonological awareness, memory, naming, and alternate rapid naming. So along the bottom here, Once again, the children's results are well in the average range, and here's their individual dots. That's phonological processing. What about reading? This is our Woodcock Reading Mastery Test. 25 children are very much in the average. We do have a couple of outliers you're seeing dotted around here, and here's their individual scores. So the Woodcock does things like word attack, reading, comprehension, oral fluency, oral reading fluency, and it also gives you some cluster scores. So basic skills in reading, comprehension skills, and total reading. And I think you can see that they're well in the average range, apart from a couple of little outliers here. So finally, writing, you give the child this picture and you give them some instructions, and they have to write you a story, a narrative, and it gets scored for things like spelling and full stops and punctuation. It also gets scored for how creative is that story that they've written. So you've got contextual conventions like your full stops and punctuation, and you've got how imaginative or clever this story is. These results are so good. They're above average that I actually got a second person to score them to see, well, am I doing something wrong here? But I'm happy to say that these are the writing results for the 25 children. And let's put them into context. Here's our 100 children, and our 25 just flew in there. So on some tests, we're seeing a delay for 1 or 2 children, but by far the majority are in the normal range for literacy. So these illustrate what is possible when the child has an implant very young and has excellent intervention. Just keeping in mind that they were from a relatively high socioeconomic background. That's our prospective study. What about the next one, which is the retrospective? We followed these children beyond school age as long as we could. And what we did is, instead of testing them just once, we got all of the language data that was available and plotted it over time. So this gives us a more accurate picture of progress. How are they going? When are they starting to fall away or get behind? So the aim was to look at the child, the device, and the family factors and say which child's progress was associated with those factors. And we just focused on children who received an implant early, so under 3.5. What it looks like is this. So the big heavy red line suggests that when you're 6 years old, you should have the language of a 6-year-old. When you're 10 years old, you should have the language of a 10-year-old. So I'm calling that the magic number 1. And you'll see that on lots of the next few slides. To understand this better, I have just 6 children. Perhaps they did the Minnesota CDI, perhaps they did the Rossetti, a bit later on they did the PLS, preschool language scales, a bit later on perhaps they did the Peabody Picture Vocabulary Test. We're focusing on blue child, for example. So blue circle child got a score of 0.74. That's just below the magic number 1. And we can see their results here. So there's your blue circle. And you can see that they're falling away. So when this child was 9, their language was like a 6-year-old. Compared to purple triangle child, where we can see a rate of growth here of 1.24. That's a little bit higher than the magic number 1. So keep that 1 in mind of what that means. We looked at over 1,000 records in our database, and we came up with 460 children who had done a receptive test, at least 2 tests, at least 6 months apart to look at progress. Some of the children were tested up to 14 times over the years that we've seen them. And on this side, we've got expressive. Less data because we don't have the Peabody Picture Vocabulary Test in that set of data. Calculating their slopes, we also looked at child factors, boys, girls, cognition, device factors, how old were they when they got their hearing aids or implants? Did they use old legacy speech processors when they started out? And family factors, mum's education, the home communication, sign or oral, whether the family needed an interpreter or not. So keep those factors in mind. And this was the result. The average for receptive, so that's the comprehension side of language, was 0.81, not quite the magic number 1. And expressive was 0.67. Keeping in mind this is a retrospective study that includes everybody. And this is what 460 trajectories looks like. It's not very useful, but it's colourful, and it suggests some of the children are falling away, some of the children are putting on more language in one calendar year than we even expect. This is a wonderful result. So typical is our hard, heavy dashed line there. So looking at 460 lines like that doesn't help so much. So we looked at it from the factors point of view. And this is the result. The factors that were significantly affected with whether the progress was better or poorer were the cause of the hearing loss, cognition, whether they had another diagnosis, their age at implant, what speech processor they started out with, socioeconomic advantage, mum's education, and home communication. So on this side, we have receptive and the significance levels, and on this side, we have the expressive tests here. So what does this look like? I'll just orient you to the slides. Here's our magic number 1. This is the goal we need to get to so that you're putting on 1 year of language ability every 1 calendar year. That's the normal growth we want. And along the bottom here, we've got all the different etiology groups. These are the most common etiologies. And we found that children with a genetic, non-syndromic hearing loss was their cause, did significantly better, for example, than children who had cytomegalovirus or CMV as their cause. We saw the same result for expressive also. And just to orient you, this is the 097. What we're wanting is that number 1. Okay, this one, genetic syndromic, straddles the line. Some of the children are achieving 1 and some are less. So that's the way to interpret the next few slides. And here we have now communication approach. Along the bottom, sign, Auslan, sign and speech. This is speech with a little bit of sign support. Oral is our biggest group, and auditory verbal is a small group. The auditory verbal children, I just point out, it is a smaller group, but they're significantly better language progress than all the other groups. And cognition. So this is the result where the children, most of the children have normal learning ability. Smaller group have, we've expressed it in IQ here, and the cognitive delay or disorder in this group here. And we do see that significant result for both receptive and expressive tests. So the children in the normal range are more likely to get that language growth. That's the number 1. And finally, age at implant. So here's the children who received it early, from 3 months to 12 months, straddling that number 1. And here's the children who received it at older age groups. So I hope I've convinced you of the importance of early access to hearing for language. We know that receptive is better than expressive. We know that we should provide counselling that carefully talks about cognition and other comorbid diagnoses. And the child needs early hearing so that they can have thousands of hours of good language input going in. So to summarise, it seems to be for speech perception, you can have an implant under 18 months. But for, oh, sorry, I just clicked through those. Let me go back. If it will let me, please go back. Yes. Before 18 months for speech perception, before 12 months for, let me start again. Before 18 months for speech perception, before 12 months for optimum speech production, before 9 months for optimum language, and before 12 months for literacy. So what are other countries doing? In fact, in the US, what are all the different states doing? It's a very complicated story for different countries having different pathways. We know that most countries, about 70%, do have national or local guidelines for age at implant. The average differs though, from 18 months in some countries, 4 years of age in other countries. In the USA, presently the FDA says it's suitable to go ahead after 9 months, but the median age at implant is 16 months. Australia, the average age at implant is 9 months. So we can see that there's some differences across pathways and age at implant for lots of different countries. This is only a very brief look. I'm sure there's lots of other resources that I could have looked at. So just that caveat. So what are the barriers to going ahead early in your country or in your state? We wanted to introduce a implementation framework to think about those barriers. So implementation science is about what are the real life, real world contextual factors that are affecting uptake of an intervention. In this case, the intervention is cochlear implants. Is that intervention, cochlear implants, being delivered in the way that the evidence is recommending? We've recommended since 2007 that children having implants under 12 months have better language. So we keep saying the same thing over and over, but countries are definitely not going ahead under 12 months, and certainly not many are going under 9 months. So cochlear implants fit into an implementation science framework because they are a complex intervention. And I've got a lot on this slide, so I'm going to spend a few minutes here. Atkins gives us all these ways to think about why is that intervention not going ahead. First one is knowledge. I mean, people know about cochlear implants, but perhaps there's differences in their knowledge about pathways, how the child progresses from newborn screening to hearing aids, or even bypasses hearing aids and goes straight to cochlear implants. In the Melbourne program at the moment, we don't have a hearing aid trial. If the child has significant, profound bilateral hearing loss, they may be fast-tracked to bilateral cochlear implants. So knowledge about pathways, it differs for different countries. What about skills and competency? Do you have people in your team that have that specialist knowledge? Do you have pediatric anaesthetists who have specialty skills for children having implants that young? Skill-wise, in Melbourne, we've been lucky to have a peer review meeting every Monday for the last 40 years, where we review all of the children's cases. The most experienced surgeons and speech pathologists and audiologists mentor the less experienced team members. So I think we have great leadership and skills there. What about social and professional roles? We found when we visited many countries that sometimes there's one person at the top, a dominant person in that group who is making all the decisions, rather than it being a multidisciplinary team. What about beliefs about capabilities? Sometimes there's a feeling of optimism in the group, or a good self-esteem in the group, or perhaps there's pessimism. Oh, we couldn't do that. We won't even, oh, how would we change practice? We can't do that. So versus pessimism, which is the next one, optimism and pessimism. We can look at the Lockheed data, the longitudinal outcomes data, certainly my literacy data, showing that children can be in the normal range if we go ahead early. So I think we should have great optimism. What about consequences, outcomes? We all know those horror stories where somebody says, I know one child that this happened to, or I know one child that it didn't work. So I think we have to be very careful with understanding the real factors and the likelihood of events occurring. Reinforcements and rewards. This is complicated because sometimes the reward is a long way away. So long-term language, First of all, the child is not speaking, not responding. What's happening here? The reward of spoken language is a long way off. So it can be difficult to keep going, keep going, keep going. Is the reward even wanted? Perhaps there are certain populations that do not see spoken language as even the goal. It's not wanted. It's a different reward or a different reinforcement that that group is looking for. Intentions, does that clinic or early intervention program have a strategic plan? Have you been as a group through one of those strategic planning days? They're horrible, I know, but it is good to have a strategic plan to move towards a goal, which is the next one. Are the goals clear? Are we measuring the right things? Who are we helping here? Whose goals are these? Memory and attention. My best example of this is having longevity in the clinic or in the early intervention service provider. Having the same people means you have that stored memory and that understanding of resources and patterns that they understand. Oh, that's happened before, let's do this, or I've seen that case before. So successful clinics have great longevity in their staff. Otherwise, we can sort of lose the focus on the topic after a while. Environmental context, the clearest example there is FDA guidelines or people resources or material resources. We're talking about money here. What is the funding for that program? There might be individual factors here as well. We had two really bad examples in Australia that you may have heard of. Children had received their implants, but their mapping was done by a single person working alone. There were two mistakes there. The fact that they were working alone, they were not part of a team, and also they were not measuring the child's progress. So that's a really difficult problem to resolve, and certainly with child development, we can't get that time back. Social influences, I'm near the end of this slide. We have a really good change now in our feelings of acceptance of diversity, acceptance of and understanding inclusive practice and family-centered practice. These are themes that we're going to see more and more. Emotion comes out in terms of fear and fear of change and stress, burnout for team members, things like that. And then the final one is behavioural regulation. So my best example there is it's hard to break a habit. It's hard to make a change. People sort of like the idea of, oh, we do it that way because we've always done it that way. So apologies for the super quick introduction to Atkins. Once we do this, we can fit it into a framework where we think about that intervention is the early cochlear implants under 9 months. We talk about the people, the settings, inner and outer. And I've put that into context. The individuals are the team leaders, the opinion leaders, the facilitators in your team. The inner setting is your resources. What have you got available to you? What's the communication within the team like? What's the culture? Is there a tension for change? I don't mean attention. Is there tension for change? Is there a need or a want to make a change? And outer settings, things like the FDA policies, guidelines, clinical practice guidelines. Once you've decided, yes, we want to make a change, what's going to happen? Who's going to do it? Is it modifiable? Can we make this change and not have any spillover effects? And let's measure change. If we change an intervention, we have to measure that that change in intervention actually did something positive. So, to conclude, what have we learnt over the last 40 years? I can't believe I have been doing this for 40 years. So, 3 themes. We do have fundamental differences in our approaches. We need to have a bit of a paradigm shift for our assessments, and we ask ourselves what actually is long term. So I've got 3 conclusion themes here. The first one, we do have fundamental differences in approaches. I'm very data driven. I've been trained to collect data. I like playing with spreadsheets. Um, this is very much a biomedical, audiological model. And we've pretty much proven that early access to hearing is associated with better language. In this model, we understand the 136 guidelines. We write things like national recommendations, newborn screening, follow-up testing, multidisciplinary teams. It all sounds a bit medical. On the other side, we have more of an ethical point of view. This from the World Federation of the Deaf, that all deaf children have a right to sign and a fully accessible sign language should be available to the child. My point here is that this is very much an evidence approach. This is very much an ethical approach. And it's not really possible to address an ethical issue with evidence. Evidence is a great foundation, but we also have to think about how that is coming across. Data tends to be objective, but it's hard to access. It's hard to read, and it may lead to feelings of disempowerment. If you can't read this complicated journal article or you can't understand all the factors, you may feel that you're removed and not part of that process. In an ethical point of view, it's much more subjective and it's about the deaf person's lived experience. So individuals and families will interpret information based on what's happened to them, their own perspectives, their own. So persuasion requires empathy and understanding, not just evidence. And even the fact that I'm jumping from side to side here, I don't want to use the word that we've got sides, this side versus that side. We shouldn't have any sides at all. I mean, it helps on a slide to have sides, but we shouldn't have any sides. It's about the child's journey. What does the child need at this time? What does the family need at this time? So meeting in the middle should be about this side, I'm using the word side, but this side having better data collection. What are the outcomes if the child has early access to sign from birth? How is that being implemented? What kind of fidelity is that being implemented? Collect that data and meet us in the middle. And then for us, who are all about spreadsheets and collecting data, we need to use our very best family-centred practice guidelines when we're counselling. So my next, what have we learned? Is this question, have our innovations, newborn screening and early cochlear implants, actually resulted in happier children? So I'm not saying that we need to stop measuring speech perception and speech production and language and literacy, but perhaps we need to also add quality of life, psychosocial measures, identity, confidence, happiness, having friends, having equal opportunity. Consider these not just at school entry or 9 years of age, as many of the literature have done, but in terms of life events, starting school, moving out of home, getting a job. And this is not my idea. I'm not pretending that's my original thought, but it's very much the ideas of the Poncho team of researchers. So the third theme, if you like, is that we still haven't really followed these children right into adulthood. There's very few studies that have looked at the current children who received implants under 12 months or received implants under 9 months and looked at them right through to adulthood. I've got a little asterisk there just to point out that we are trying to do that right now, where we've got children who received the implant under 9 months, and we're surveying them. If they've used it for over 10 years, what are they doing now? Where are they? What are their jobs? What's their happiness? What's their identity? So we're trying to address that right now. So watch this space. And I just want to finish with Teresa Ching and her Lockie team. They remind us that there is less evidence right through into adolescence and adulthood. And once again, that idea that Spencer, Tomlin and Gantz reminded us that we're talking about current cohorts, children who receive the implant young, they probably have two, and they're using the current speech processor. So thank you very much for your attention, and it's been a lot of information, and I hope that we have the opportunity for some chats and some questions. And thank you once again to the organisers for this opportunity to share some of our data with you.